Thank you, everyone who's already joined us for our webinar today. We're just going to wait another few minutes to let everyone log onto the call, and we'll start in just a minute. Thank you so much for waiting, and welcome to everybody who has just joined us. Thanks for joining us for this installment for the Root Cause Coalition's How-To webinar series. My name is Rachel Carlson, and I'm the membership coordinator here at Root Cause Coalition. Before we get started, I just want to go over a few logistical items for this webinar. Attendees will be in listen-only mode for the duration of the webinar. This webinar is being recorded, and a copy of that recording will be available to view on our website at rootcausecoalition.org later this week. Our panelists will be taking audience questions at the end of the presentation. If you have a question during the presentation, please type your question into the question pane located usually on the right side of your screen. We are so excited to have our esteemed panelists join us to share their expertise on how healthcare organizations can advance racial equity and create business value. At this time, I would like to pass it off to Lakshmi and Ryan from FSG.
Wonderful. Thank you so much, Rachel, and really excited to be here, everyone. Ryan and I, we work, as Rachel mentioned, for FSG. I just wanted to provide a little bit of background on who FSG is and where all this is coming from. So Rachel, can we move on to the next slide, please? Great. So FSG is a mission-driven consulting firm that works across sectors to drive social change. And we do this in three ways. So we do hands-on consulting, where we advise private sector organizations, nonprofits, and foundations to create social impact. We also undertake evaluations to understand the impact of that work. The second sort of piece of work that we do is idea generation through research papers, articles, blog. We learn about what are the best effective ways to create social impact, and we share that. We think of ourselves as a learning organization. And the third piece is we have two communities of practice, which is a group for practitioners of shared value and collective impact. So if you go to the next slide, I wanted to talk a little bit about specifically our U.S. health practice. So FSG works on a variety of different issues, both domestically in the U.S. as well as globally. We do have a U.S. health practice, and I wanted to just share a little bit of context on that. So we work with a variety of different stakeholders and work with them really to create optimal and equitable health outcomes. So, as the image here shows, we work with hospitals, health systems, where we've advised organizations like the Children's Medical Center in Dallas and Kaiser. We work with nonprofit organizations that are, some of them are listed here. We work with pharma companies and foundations as well. And the idea is that in our work, we help and support clients to strategically adapt their strategies to the changing healthcare landscape, or we link sort of their core work in the healthcare space to also non-health areas such as education and community development, so that it can help clients sort of address social determinants of health. So we work in the whole sort of spectrum of issues. And, our team sort of has experience of both healthcare professionals, people with analyses background and public health practitioners. So, and we enjoy sort of bringing all those different expertise as we work with our clients. So if you go to the next slide, Rachel, I wanted to share, before we talk about the research today, and I wanted to talk a little bit of where all this is coming from. So FSG, today we're going to talk specifically about the competitive advantage of racial equity, and we're going to focus very specifically on the healthcare sector. But I wanted to share that this is really a part of a larger journey that FSG and our partners PolicyLink has been on for the last 3 to 4 years. And so PolicyLink is a national leader on advancing racial and economic equity. They've been around, they're based here in Oakland, but they've been around for 20 years and they work nationally. And FSG, we've also been around for around the same time, and our expertise largely has been, in working, as I mentioned, with the private sector and other sectors to create social change. One of the areas that we work on is with the private sector on how to use their core business to create social impact. And usually, these two fields of racial equity and competitive strategy have always been thought about as two separate areas of research. But these two organizations have come together where we've combined our expertise to explore the economic consequences of racial inequity for corporations in the U.S. So in 2017, we jointly published the first report, which was titled The Competitive Advantage of Racial Equity, where we cited a number of examples of companies that have found new sources of growth and profit by driving equitable outcomes for their employees, for their customers, for their communities of color. And this year, in 2019, we published a follow-on report very specific to the healthcare sector and the financial sector. And so we're going to share insights from that paper on the healthcare sector today. Let's move on to the next slide. I just wanted to do a quick introduction of, who we are. As I mentioned, I'm Lakshmi Iyer. I am an associate director at FSG, and I have been at FSG for about 7 years. A majority of the work that I do is with private sector corporations, advising them on how to create social impact, either through their philanthropy, through their CSR, or through their core business. But for the past 3 years, it's been my honor to work with PolicyLink to really explore this intersection of corporations and racial equity. And I've done that with my colleagues, with Ryan, and with numerous other FSG colleagues and PolicyLink colleagues. So with that, I'm going to hand it over to Ryan to introduce himself and take it from there.
Great. Thank you, Lakshmi, and hello again to everyone. Thank you so much for taking time out of your day to explore this really important topic with us. So as Lakshmi said, my name is Ryan D'Souza. I'm a senior consultant at FSG. I spend the majority of my time working in our U.S. health practice and working with organizations across various sectors that are working to improve population health and ultimately advance health equity. That's a core focus of my work. My professional and educational background is in healthcare management and policy. I started off my career working with the advisory board and advising hospitals and health systems on how to improve operational and financial performance, navigate healthcare reform and value-based care. And immediately prior to joining FSG, I was deeply steeped in academic medicine as a manager at the Association of American Medical Colleges, where I led the design and launch of a service that was aimed at improving organizational culture at medical school. So coming at this from multiple angles, from the health equity lens, from the healthcare management and policy lens, from the academic medicine lens to this work that I do. As I was preparing for this, I was kind of thinking to myself, and in October, many of you are going to gather in San Diego for your annual summit, and I had a chance to be in New Orleans last year with many of you at the last summit. And the theme of this upcoming summit is health equity in our time. And I was thinking to myself, what an amazing opportunity for us to achieve health equity in our time if this group of the folks on the phone that are deeply committed to social determinants are increasingly anchoring our understanding of what it means to advance health equity and fundamental root causes, continuing to move upstream. So I want to spend a little bit of time just talking about that. And as Lakshmi mentioned, we'll also go into some specific examples from our paper, but I want to frame up this first part of our conversation by just really digging into root causes. So on the next page, what you'll see are some statistics that might look very familiar to many of you. Some of the most significant and persistent inequities in healthcare and care delivery are witnessed on the basis of race. And these are well-documented and long-standing inequities in a variety of conditions for people of color in particular. So hypertension, cancer, asthma, these are just a few that we can name here. And these inequities also extend to the differential experience of care for people of color. So research also shows us that people of color, Black Americans in particular, are less likely to receive health-enhancing and life-saving primary and specialty care. So as you can see on the next slide, thanks to a robust body of literature and to the many efforts of the folks on the line here today, that the public health field and healthcare payers, providers, and policymakers have increasingly acknowledged the substantial role that the conditions in which people live, learn, work, play, and pray, the social determinants of health, they play a fundamental role in defining the health of populations. As you can see on the next page, as a result of this, we're seeing greater attention placed on moving upstream, right? And many of you are moving upstream. So a growing number of interventions are going beyond the clinic walls. So they're addressing, for instance, the role that food insecurity and food deserts play in diabetes and obesity, seeing that outcomes in those spaces and the differences we see there are more than just differences in behaviors and biology and clinical care quality, but fundamentally rooted in some social determinants of health. Or perhaps the role that the built environment and in-home air quality plays in asthma outcomes. So in a word, your zip code plays a bigger role than your genetic code in influencing your health. And that is a common mantra that we see in this environment. But let's keep asking the question, why? Is there something even more fundamental at play here? Is there a root cause in explaining these persistent inequities across race and ethnicity? Is there a cause of the cause, so to speak? And can a focus on this root cause enhance the efficacy of these upstream strategies and also drive business value? And what you'll see on the next page is that there's a resounding yes to that question. And that fundamental root cause is structural racism. So structural racism refers to the public policies, the institutional practices, the cultural representations that can interact and reinforce ultimately racial discrimination and lead to an unfair and unjust distribution of resources that ultimately raise the risk of poor health outcomes for people of color. And as you can see on the next page, when we continue to peel back the layers on these health inequities, we begin to see that structural racism is a fundamental root cause, right? So it informs many of the social determinants of health, from access to high quality schools, to high paying, sustainable jobs, to access to healthy food options. A lot of this is rooted in even further upstream impacts when it comes to structural inequities that we see within our country. So as you can see on the next page, one example of this, of structural racism, can be seen in housing. So if we look below the surface, when we see the differences in health outcomes for communities of color, and we dig below the surface, what we see is the federally legalized practice of redlining, whereby people of color were fundamentally and systematically denied mortgages in white neighborhoods. And although redlining is illegal today, there's evidence from the National Fair Housing Alliance that discrimination persists in the housing market, right? So this discrimination that we're seeing is also compounded by business and public sector disinvestment in predominantly Black communities. And as a result of this, what we see is residential segregation, right, in one sector, in housing, that ultimately impacts another sector, which is health and healthcare, and ultimately increases the risk of exposure to health-harming conditions for marginalized communities of color. So if we're really going to shift the social determinants of health and see health equity in our time, we have to look even deeper at root causes, including structural racism. So as you'll see on the next page, this problem can't be ignored, especially when you think about the shifting demographics in our country. By 2050, people of color will be the majority in this country, and 2050 might seem like a long way away. It's going to be here in no time. And in fact, in certain parts of this country, this is rapidly becoming the reality. So we can see that there is a clear social value in addressing structural racism and promoting racial equity. There's also an opportunity to produce business value, and I want to show you that a little bit more on the next page. So that business value, what we call shared value here at FSG, is at the intersection of social needs, right? This imperative to drive racial equity, business opportunities as well, and in the context of healthcare, that might be how do we reduce costs, how do we manage our volumes, and there's also some imperatives around the specific assets and capabilities that companies can bring to bear. At the center of this is shared value. It's the way that we can enhance business performance and also drive improvements within society around us. So what does this look like for healthcare companies in particular? And I want to show you that on the next page. In a moment, Lakshmi is going to walk through and share some specific examples, but I want to take a moment to just highlight what this looks like. So in our report, in the competitive advantage of racial equity and in our healthcare paper, we profile leading health systems and commercial insurance companies that have begun to anchor their health equity agenda to advancing racial equity. So these leading companies are engaging in a couple of reinforcing strategies. And in fact, some of these strategies may look really familiar to you. So on one hand, they are redesigning the ways in which they provide core services. They are anchoring their actions in disaggregated data on race and really digging in and looking at the way that race might influence certain health outcomes. They're screening for social determinants of health and the non-clinical factors that might be impacting the health of the patients and the members that they're serving. They're embedding the concept of cultural humility and structural competence into the work that they do. They're going beyond just cultural competency and thinking about the role that structural inequities play in the way that care is delivered, and committing themselves to a constant and consistent understanding of the way that culture shows up amongst their patients. And then they're extending their services beyond core clinical services to consider non-clinical solutions. Then further upstream, they're even looking at how can we shift the conditions that affect health, whether it's shifting public policy or strengthening economic vitality, and that might be seen in place-based investing. But what I also want to underscore is that these strategies don't exist in a vacuum. And where racial equity really comes into play here is what we can see on the next page. I think what really distinguishes the work of these companies is that they're recognizing that place and race matter to promoting health equity, that health equity depends on racial equity. And this is reflected in organizational culture that is really embracing the role that race plays. It's more than thinking about social determinants. That's an important aspect of this, but it's really saying, well, what are the fundamental root causes and how is that reflected in our organizational culture and how we approach engaging and embracing the communities in which we operate. It's also reflected in very strong diversity and inclusion practices. It's reflected in leadership support and accountability, and then fundamentally in the types of cross-sector partnerships that these companies are seeking to form. So as a result, the companies that we profiled, and I think by extension, I think the broader healthcare system and companies operating in this environment are not only poised to advance racial equity, but they're also poised to enhance their business performance. And they can do that by delivering on the triple aim objectives of better population health, better experience of care, and lower costs when they continue to move further and further upstream and address the fundamental root causes here, which include structural racism. So we're eager to spend a few minutes just sharing some examples and hearing your questions at the end. And with that, I'm going to turn the presentation over to Lakshmi.
Great. Wonderful. Thank you so much, Ryan. So I'm going to take the strategies that Ryan just shared and try and bring them to life by sharing a few examples. The idea is we're not going to go in detail into sort of specific case studies, but share sort of certain practices or the how specific companies move to action with you right now. So if you go to the next slide, let's actually start by talking about how ProMedica sort of made some business model innovations to implement this first strategy. So as a reminder, the first strategy that Ryan described was where organizations are really redesigning the ways in which core services are provided, right? So this requires businesses or organizations to go beyond the business as usual and rethink how those root causes affect their members, affect their patients, and how might the service delivery be shifted to take that into consideration. So as you might already know, ProMedica is the 15th largest integrated healthcare delivery system in the United States and serves communities in about 30 states. It operates 13 hospitals in Ohio and Michigan. So they, have done a lot of different things in this space, and there are detailed case studies available online, but I want to particularly highlight two things that stood out to us that fall within this first strategy. So one of the sub-strategies that Ryan spoke about is can organizations really understand those social factors in addition to clinical factors, right? How can organizations do that systematically? So ProMedica has actually added a new step in their service delivery by screening patients and employees for 10 social determinant of health indicators. So these include, food insecurity, housing and safety, financial strain, childcare, transportation challenges. And although most hospitals screen their patients to better understand how these social issues or how these social determinants of health affect their patients, ProMedica, we think, sort of stands out because of the consistency that they bring into this process, right? So screening is really embedded in their clinical encounter workflow, and they screen all their patients both in primary care practices as well as the inpatient setting for food insecurity, and now they're expanding it to their specialty care setting as well. And by screening patients and asking what they need rather than sort of relying on assumptions, the idea is that the organization is trying to reduce biases. So as part of this research, we were talking to the president of social determinants of health at ProMedica, Kate Summerfield, and one of the things she said really stood out to us, which is she said, our providers are often surprised by the patients who screen positive. Right? Sometimes even if you have cared for the patient before, this process may help you find out underlying problem of food insecurity or domestic violence issues that you perhaps did not know of. So the nutshell here is changing the service model to reduce the biases and the consistency. The other practice that ProMedica does that I do want to touch on is, what happens once this step has been added. Right? So once a patient actually screens positive for a social determinant of health indicator, then that issue is resolved by, let's say, writing a prescription for food or connecting the patient for free financial coaches or identifying community resources and services such as a community health worker or housing. And so we've listed some of those services here, and some of them are provided, sort of through a direct delivery model by ProMedica, and some of them they rely on a referral model. So this is where partnerships really come into play, right? So they're partnering with other organizations to address the social determinants of health that they identified in their process. So I'll actually move on to the next slide, but I think what I want, the key takeaways here are about really rethinking the business model and innovating some processes here. On the next slide here, we continue to talk about the first strategy, and we'll share some examples from another organization. So, one of the first things that Ryan sort of shared was about the power of anchoring your actions in disaggregated data, right? At the end of the day, racial health inequities can only be eliminated if you have high quality information, right? So like we saw in the previous example, data can be a starting point for identifying what drives the inequities and then solving for that. And so leading companies like Cigna, they're beginning to sort of collect and track the data on patient race, ethnicity, language, so that they can then disaggregate the clinical performance and then make adjustments to really improve health outcomes. So, Cigna does a lot of different things, but one of the things that they do is they use geographical information systems. So there's GIS software that really overlays the provider network and customers with other variables like education or food or infrastructure. And the goal of sort of overlaying those different variables is that it allows them to understand what are the opportunities to improve health outcomes based on the quality of those variables, right? So is this in a place where there is food insecurity, or is this in a place where the infrastructure is really poor? And then are you seeing sort of some result in changes in the clinical outcome? So they're sort of using data to make certain decisions. And we've seen sort of a lot of other organizations beginning to do that as well. Another strategy here, and I know we're jumping from one to another, but the idea is to give you all a flavor of what is going on, is the power of cultural humility, right? How do you embed cultural humility in the way that the service is provided? And, as I think, Ryan, you began to mention this, but the idea is that cultural humility sort of goes beyond cultural competency. The idea is that it encourages people to be curious and have some sort of self-reflection and really engage in a conversation with that sense of curiosity to really understand the whole person. And so Kaiser is sort of doing a few different things, right? So they, on one hand, they sort of provide cultural training, but also they're trying to increase the sensitivity of their employees to better understand the socioeconomic challenges that communities of color face, right? So the history that Ryan just shared, the hope is that that is something people are aware of and truly understand, so that they have not just cultural competency, how do the people from different communities behave, what are their cultural norms, but also where are they coming from? What are some structural barriers that have influenced where they are today? So there are, when we think about, and I think this distinction is really important when we think about diversity and inclusion, that is often there in most organizations, but I think how can these practices go beyond to also understand what influences equity? And that's a different conversation than just focusing on diversity and inclusion. I want to talk a little bit, if you move to the next slide, I want to talk a little bit about the strategies that are that an organization can use to sort of influence the context in which the organization exists, right? So if you go to the next slide, the reality is that all the strategies that we just spoke about sort of fall within, to some extent, the four walls of an organization, right? So they are often implemented by people sitting within the organization and influencing their internal processes and practices. But the reality is that there are certain factors in the context of an organization, in public policy, in cultural norms, in societal norms that continue to perpetuate some of these inequities today, right? And some of them may be more explicit and obvious, and some of them may be some of them may be more implicit, or some policies may be inadvertently influencing people of color in a negative way. And the idea is that certain organizations are taking the lead to really understand what those policies are, what those practices are that influence their patients, influence their communities, and they're trying to take an active role in tweaking that. So one of the examples that we share in our paper is, again, by ProMedica, where in 2017, with the help of multiple community partners, they, including an organization called the Advocates for Basic Legal Equality, which basically provides legal services and advocates for low-income individuals, they passed a new zoning ordinance that basically limits payday lenders from opening up new branches in an already oversaturated market, right? So there is obviously links between things like that in your society to the health of your patients, or the health of people in your community, as Ryan kind of described in the slides before. The idea is, can an organization really understand that and use its ability, use its sort of position in society or its public policy chops to change some of those policies and practices. The other example that's mentioned here is also really interesting, and this is where sometimes it's, the partnership between philanthropy and business becomes really interesting. And, oftentimes philanthropy may tend to be, or community benefits may tend to be a little bit siloed from the core business, but there is real benefit in aligning those departments to the vision of the entire organization, right? So ProMedica as a company recognizes that place also matters. And so it's investing $10 million in a CDFI to create this impact investing loan pool to improve the physical infrastructure in that community. And the idea is that it's not only going to sort of get back its principal investment, but also have a financial gain, right? And there is another sort of $50 million sort of philanthropic dollars that it's investing in some community development efforts. So again, that's where you can think about different parts of the organization that come together to solve this problem in a more holistic, sort of concerted way. The one thing I want to talk about is, I think Ryan started mentioning this. The idea is that the business benefit of all of these strategies is that it either will end up reducing cost or it ends up allowing you to sort of reach sort of patients that you perhaps weren't reaching before. The reality is, we started asking questions to all these, companies that we interviewed about to what extent are they measuring the impact of this. And the reality is that they are still early in that process. I think ProMedica, to some extent, probably I would say is leading this space, where they've started actually measuring, doing analyses on the healthcare costs that have been saved, or the reduction in emergency department usage, or the reduction in readmission rates. But that is still something that other companies and other organizations still have a long way to go. The one thing that I want to say before I kind of end this discussion and open it up for questions is what holds all of these strategies, right? So an organization can have all these strategies and have really great ideas of how to influence health equity, but it cannot survive without very strong internal enabling conditions. And I know Ryan introduced that before. And we started talking about that as well, right? We started talking about diversity and inclusion being really important, but not limiting it to just that, but really having the focus on equity. So if you go to the next slide, you'll see some of the factors that are essential catalysts for this work to happen. So organization culture is really important, but the culture that really recognizes that race is important and race matters in addition to place. Leadership support that kind of has an accountability structure for advancing racial equity, as well as strong D&I practices. So ProMedica, for example, if you think about the leadership kind of structure, it actually has a president of social determinants kind of position, which is an executive role that reports directly to the CEO. And this is the individual who I was talking about earlier. Her role is kind of looking at not only how the core, how sort of community benefits can help improve social determinants of health, but also how the core business and the core clinical practices can advance health equity. That team also has a multidisciplinary staff, and this is where when we think about diversity, it is also about diversity of experiences and perspectives that are in the room. So their staff includes community health workers, urban planners, a physician with data analysis background, and so it actually hires people with different kind of experiences. And then shifts in HR policies. This is interesting too. I mean, through our research, we've found that sometimes HR policies, the way they are, can inadvertently sort of exacerbate some inequities, particularly for entry-level or frontline workers. So, ProMedica sort of proactively recognized this and waived the direct deposit requirement for new employees who were in job training, right? And provided them connections to credit union. So these are sort of small internal practices that go a long way in supporting employees of color, but also really creating an organizational culture that advances health equity and racial equity. I think I will pause there because I think the next slide I already talked about the business impact, Rachel, but maybe we can pause there and go to the questions. So here, go ahead, Rachel.
No, you go ahead.
I was just thinking a note. I mean, we'd love to pause and hear questions from the audience. These were questions that we had in mind. We're just curious about where different organizations are and what it would take for your organization to effectively advance racial equity. And we recognize that every organization is in sort of a different place in their journey, and it's fine. It's about just thinking about if that intention is there internally. But also, what are some other practices? We completely recognize that our research may not be comprehensive or exhaustive of all the interesting, innovative practices that, perhaps some of you have already undertaken. But we are curious to listen and hear and understand what those practices are. So with that, I want to pause and just open it up for more questions.
So now you can use this time to type any questions or any responses to these questions into the question pane on the right side of your screen. And we will go through it and start reading some of those responses and reading those questions out in just a few minutes. All right, thank you everybody for submitting questions. Obviously, as we go through this question and answer section, please feel free to keep submitting them. We'll try to get to as many as possible. So the first question we have for Ryan Lakshmi, one of our participants is curious to hear a little bit more about what the results and impacts have been of ProMedica and other organizations implementing these strategies.
Mm-hmm. Yeah, I can take that, and I know I didn't pause too much on that slide as well. I think we featured 4 companies in our research, and the reality is, I would say they are very much in their early stages of building strong evidence that'll guide their that'll show impact. But I would say ProMedica in particular is leading that space. So if you go 2 slides before this one, Rachel, we sort of start talking about that, right? The one before this, yeah. So the one after. Yeah. So over here you can see some of the business and social benefits that ProMedica has been able to capture in numbers, right? So this is the reduction in healthcare costs or the reduction in emergency department usage and all of that. And I would say that said, I think a lot of the reason we featured the 4 companies that we did is because they definitely have the intentionality that this strategy is not being done just because, yes, part of it is it's the right thing to do, but also because they very clearly see the link to the business. And they very clearly see the link to, what it means to do this work, reduce cost, improve the quality of care, also have a better reputation. And they really see that link to the business. So, I think even United Health Group, which is not an example I shared today, but we featured in our report, they have, I believe, a dashboard that is, presented at the executive level where they are capturing some of the data very specific to health equity. So I would say the field is very early in this space, but they have started capturing some of the impact. Would you add?
Yeah, and I'd add on to that is this is a part of the journey that even many of you and others are doing to move upstream. I mean, there's a pretty robust body of literature that's showing the role of social determinants of health in impacting some of your key metrics and indicators as healthcare companies and healthcare entities, whether it's how do we manage our per member per month spend as a payer, how do we improve the experience of care as a provider, understanding that increasingly within our value-based care contracts, there's not only a piece in there about the experience of care, but then also cost of care. So this is very much an imperative that can't be ignored. So how do we become even more effective in addressing this imperative? It's moving further upstream, and it's experimenting, with different strategies that will enable us to deliver that business value for various stakeholders.
Great, thank you. And a few participants have asked about what are some ways that maybe smaller or rural organizations might be able to engage in this health equity work, and what are some first steps that organizations that might have fewer financial resources or fewer staff, what are the things they can do to start this sort of journey?
Yeah, thank you for that. And it's an excellent question, because sometimes this can all feel very overwhelming, right? We see these big integrated health systems doing these amazing things, and you say, well, what about me? I'm a community hospital, or I'm a fairly qualified health center, or I'm a critical access hospital. How do I engage in this? And I think one thing is to build on some of the work that you're already doing, right? I think many nonprofit health systems right now are required to do community health needs assessments. So start with some of the work that you're already doing. I don't think there's necessarily a need in some places to reinvent the wheel. Some of the existing practices that you're engaged in today around community benefit and how you're beginning to surface what the needs are in your communities that are by statute that you must do, dig into that a little bit further. Continue to ask questions around, well, gosh, I'm seeing that there's differential access to care in places in our community. What's the additional research that we might do here to try to figure out what's really at play there? What partnerships do we already have in place with community-based organizations, with other stakeholders that we can continue to foster and cultivate under the umbrella and under the banner of racial equity? So I'd say don't feel overwhelmed. Don't feel like you have to start from scratch. Figure out ways where you can build on programs and practices that you already have in place.
Great, thank you. Another participant asks, what is pushing the healthcare industry to change their practices? Or why are they recognizing this need now to address racial equity?
Right. Yeah, absolutely. I think the trends that I think that we witness and that many of you are witnessing is we saw with the passing of the Affordable Care Act, now 9 years ago, but about 5 years now into some really deep implementation, is that there's definitely that orientation around the triple aim, right? There's that focus around how do we improve population health, how do we improve the experience of care, and how do we manage and ultimately lower costs. That framing from IHI that has ultimately kind of made it in as a fundamental aspect of healthcare reform and value-based care is deeply rooted. So I think definitely healthcare reform, and I think this push towards value-based care has been an important piece of this. And I think healthcare companies, I think policymakers, providers, various stakeholders are then saying, well, how do we actually get at those root causes, right? So I think it's really the point that we've been making today is, well, if I need to fundamentally kind of execute on the triple aim, what is it going to take? What are the things I need to do differently today? And I think definitely that push towards value-based care, the march towards how do we fundamentally improve the experience of care and manage costs are really pushing folks in this direction. And it's bringing additional nuance. It's bringing additional focus to say, well, what's really upstream? What role does racial equity really play in this, especially when we look at our own community health needs assessments and we look at our own data, and we're finding pretty persistent and significant inequities on the basis of race. So we need to move even further upstream. And like we highlighted today, there are various partnerships and approaches that can enable that and make that successful.
All right, thank you. Another participant asks about how these example organizations, how did they determine which steps to take in advancing and addressing racial equity?
Yeah, I think there are a number of different approaches, and I think if you go back and think about strategy one, for instance, one of the very early places you can start is start to look at your own data. You're generating payers are generating tons of data around healthcare utilization and cost. Providers have tons of data flowing through the EMR, maybe imperfectly, but tons of data even internally that they can begin to leverage and work off of. So again, I think it is really starting with what you already have in front of you. It's not necessarily kind of recreating the wheel. You have information coming in from various sources. It's starting with the data. I think starting to ask yourself some questions of, well, why are we seeing some differences here? And using that as the platform to begin to move forward. And I think it also touches on the earlier question that I made, the earlier question and the response I provided earlier is start with what you have. And I think what we see in the companies that we profile is ProMedica didn't get here overnight. A lot of it started off with really just looking at their own data around childhood obesity. And it was a series of questions of why, and backing up and going further and further upstream that ultimately has produced and kind of fostered this more robust approach that they have today.
Yeah, and I'll just add that, totally agree, Ryan. I'll just add that I think we often see this in, particularly in this space of advancing racial equity. I think a lot of the organizations that we featured sort of started either where they had the energy or where they had resources or where there was one question and they asked why. But I think part of the reason why we've documented this and sort of laid out these two strategies is so that you have a nice place to almost start and see the menu of pathways that you can use to start this work. There probably are more, but this is our sense based on our comprehensive kind of study. And the idea is that use this and kind of ask yourself the question of where you could potentially start.
Thank you so much. Another one of our participants asks about the funding for this type of work and what funding streams are used and what challenges might be faced in receiving funding to do racial equity work.
Yeah, I think we've got a couple of different perspectives on this. I think I have maybe two perspectives on this. I think one is like I mentioned earlier, I think a lot of this, when you start to again kind of peel back and get to the root causes here, you're going to find that a lot of this is impacting some of your fundamental business metrics, like per member per month spend, like your readmissions penalties. And I think starting to frame up some of that business case around some specific metrics that you already have, what you'll find is that there's some savings and some opportunities there from bringing that more kind of deeper intentionality around racial equity that's going to flow through to some of the metrics and the bottom line sort of indicators that you're working with today. I think the second piece is that, as we mentioned, there are some internal catalyzers that make this important. There is a fundamental adoption and recognition that this work is important and that resources should be directed towards advancing this work. At the end of the day, you have to make a decision and say, is this really a problem for us? Is structural racism something that we want to begin to tackle in a variety of different ways? Understanding its core place and cause when it comes to health outcomes into financial outcomes for us as a company. So a couple of perspectives I had there, but I'm sure, Lakshmi, you have some other thoughts here as well.
No, I was just trying to think through, Ryan, I don't have my thought fully formed here, but I was trying to think through the example that one of our interviewees gave about the chief medical officer being in the same room with the chief diversity officer. And the idea is that sometimes part of the reason why the funding doesn't come through is because there is sort of one entity doing this work in a siloed way. And, to Ryan's point, if you're able to connect this to the business results, or if you're able to kind of really connect this to quality and, metrics that matter, there will be a way for the funding to happen. That's kind of so it's just an add-on, but not a totally different point.
Yeah.
Great, thank you so much. Another one of our participants asks about what government organizations, such as HHS or the NIH or the CDC, what are they doing in terms of engaging efforts to improve racial equity within their institutions and within their healthcare?
Yeah, so I think this is another great place for partnership and for accelerating some of this work. So, there are a variety of kind of work that's happening, and we have a little bit of insight here, and I'm sure there's even more knowledge beyond what we have here on the phone today that can give context to this. But even think about your accountable communities and accountable healthcare models right now that's coming out of CMMI, right? Really thinking about the ways that social determinants of health are playing into care delivery and costs for Medicare patients. So we see that as an initiative. We also know that HHS, CDC have their offices of minority health and focusing on efforts for communities of color. So I think there are a variety of different insertion points and opportunities for collaboration that we're seeing within government. I'd also add that think about government not only at the national level, but also the local level. So think about your public health departments. If you haven't already, I think a great place to see a partnership amongst government in the form of public health and hospitals and health systems and community-based organizations is, of course, not only within the Root Cause Coalition, but also within the Build Health Challenge. I think it's a great example of work that's been unfolding across the past few years, showing how public health and the resources within those departments and the existing work that they're doing around assessing public health and population health can be intertwined and interconnected with the work that hospitals and community-based organizations are doing to move beyond the clinic walls. So also think about what are there ways for us to connect locally with our public health departments and with our schools and other public sector entities as well. So I think there's some even greater opportunities for innovation at the local level when you think about the work that can happen there.
Great. And sort of similarly, speaking on community engagement, a couple of people have asked specifically about ProMedica and just in general, what are some ways health systems can increase or just bring in outside community-based organizations and community members into this work, and how can healthcare organizations incentivize that participation?
Yeah. Maybe a couple points on this. One of the things that really resonated with me in doing this research, when we think about racial equity, I mean there are some deep-seated, harms and marginalization of communities of color in the history of our country. And I think part of that is having the humility of as an organization to recognize that that is a part of our history, and coming to the table and wanting to engage with other community-based organizations and partners with that acknowledgement in mind. I think that's an important thing to note. And I think what's also implied in this question is that, yes, you're not doing this on your own. Another thing that really resonated was the work that ProMedica did here. So when we talked about the place-based investing and some of the funds that are being set aside philanthropically around improving larger community health, before ProMedica forges any relationship with a community-based organization, they are talking with and engaging the community first. They are not bringing the CBO to the table and saying, hey, community, this is who we're going to work with on this. The community is participating in that. So there's definitely this element of authentic community engagement that doesn't, I think, happen in a vacuum. I think there's really a way for organizations to learn. I think just like us, like PolicyLink has been an advisor to us too in thinking about health equity. Like we, in doing this work, had to think about this from multiple lenses and dimensions. So I think it is about thinking about who your community partners might be, thinking about where there might already be some existing relationships with community-based organizations, but also then second, recognizing that it's not just coming to the community and saying, hey, here's who we're going to work with, here's what's going to happen. It must truly be participatory and really rooted in authentic community engagement and a recognition of the role that structural racism has played in specific communities over time and has continued to kind of perpetuate and been seen today. It's coming with that humility as well to the table.
Thank you so much. So on the other side of the coin, a few people have asked about how to maybe engage hospital system leadership in conversations about social determinants of health and about racial equity, and how to start driving that change, for strategies for having that conversation to drive cultural change within your organization.
Yeah. I think it's maybe a couple pieces on that. I think one that stood out to us from the Cigna example, sometimes when you can show to your leadership that you're out in the public and you're having conversations and that you're doing good work, that can also be a way to bring their attention to this. To say that, hey, I went to this conference and I presented and I got this really great insight from colleagues and great feedback around sort of our perspective and what we want to do in this space. That can also be a great motivating factor. And we saw that in some of our conversations with Cigna, where they were bringing data to the table saying, here's some of the kind of pilot work that we have started doing. Here are some of the conversations that we've been having in the industry with our peers and our partners. We see a great opportunity to do this, and it's bringing data to the table and again, this doesn't happen overnight. It's coming, I think, over time and showing some of the early impact that you're having, or what you kind of propose what might happen as well. Kind of coming to the table with that information and that data to do this is a very important factor.
Yeah. Definitely, I think data is one thing. The other thing we've seen is there is something about, so there are a few different ideas, right? And this is both from what we've seen in the healthcare space, but also, I think the question was about how do we educate our leaders about social determinants of health, but also racial equity. So I think this is something we've learned both from the healthcare space as well as other organizations and other sectors. One, it's data, and as Ryan mentioned, connecting it to the business. I think part of it is also showing that other leaders, like other leading peers, are kind of already thinking about it. That's, it might seem a little strange to kind of use that as a benchmark, but the reality is there are a lot of leading organizations that are either already on this journey, CEOs are talking about it already, and they have started that journey. So kind of showcasing what others are doing is something important. I also think that it's some power in sometimes in some organizations, and I don't know how much of this is, I think particularly when it comes to race and racial equity, some of that journey is also internal, about people getting comfortable talking about it. I think we saw in our research that there's a lot of comfort in talking about social determinants of health, but sometimes organizations stop there, and there is a little bit of discomfort I'm not saying with everybody, but sometimes to talking about taking that one step back and talking about race and racial inequity and structural racism. So there is a little bit of executive, I would say, education that is also important to kind of bring that comfort in talking about race and racial inequity and how that's actually linked to the business. So that's actually something, when we released this paper, that's actually something we got a lot of requests for, because there were certain individuals in the organization who got it, but felt like, the leadership required some sort of a safe space almost, right, to talk about it, to learn about it, and get comfortable even using the words.
Great. Thank you so much to our presenters, Ryan and Lakshmi from FSG, and to everybody who participated and submitted questions. We are at 2:30 right now. I don't want to take anyone else's time. This webinar has been recorded and will be posted on the Root Cause Coalition website later this week. If you have any questions, feel free to contact either the Root Cause or Ryan and Lakshmi. Their contact information is up on the page. Thank you so much to everybody. We hope you have a great rest of your week, and thank you for joining us today.
Great, thank you.